Good morning, it's Dr. Rutledge, and I'm going to talk to you today about our seminar, and I'm honored to be in charge of getting things started. So I have a brief introduction. I'll go ahead and share my screen. So we're going to talk about reflux. I hope we'll find out more about why it happens and how to prevent it at surgery and how to resolve it if it occurs post-op. So I'll go ahead and put myself away here. So we're going to talk about GERD, the causes and treatment, surgical technique errors versus lifestyle, prevention and treatment. Those are kind of the topics that I think I've been tasked with presenting today. And I'm reminded of the Terminator movies. Come with us if you want to get your GERD better. So mini gastric bypass is, I guess, a prominent part of the presentation, given that I'm in charge of getting started. And one of the things we like to say is that with some understanding comes both power and safety in the surgery. And again, I volunteer that anyone wants to talk about the surgery, you're welcome to contact me. I also would like to take a moment and thank Dr. Kular and Dr. Magenda, who kept me safe in India while we were trapped during the pandemic. And imagine having to put up with me for a year. So I want to thank them very much for looking after me and taking care of me during that time, although they wouldn't let me in the operating room because they said I was too old. I'm also would like to take a moment to thank my new partner, Dr. Halil Ilan here in Tijuana, and our upcoming practice in California. And I'd also like to honor Harris Khwaja and the IBC for what they've done. These seminars have been popular and well done, and I'm honored to participate. I want to point out a paradox, and we'll probably not be able to solve this, but the MGB paradox is that we have a lot of people, including myself, who reported good results with the MGB, but we've also had a number of presentations and publications of either poor weight loss, excessive weight loss, bile reflux, which I think we're going to talk about today, but also leaks and death. And of course, I think we'll deal with that a little bit. Just as a reminder for the opening here, there's nothing more in the MGB than just routine general surgery. And a hypothesis that I have for our presenters today is if you're seeing a lot of reflux in your patients, keep an open mind, maybe it's you. The MGB we think done wrong can have technical errors leading to reflux, and postoperative management as well can be done either more or less well. So that's what we'll think about today. Excuse me. Our objectives is to tell you something you don't know, something new, clear up some confusing things, and maybe tell you something you think you know is wrong. Just a reminder, this is the MGB, and it's nothing more than good old general surgery, more than 100 years old. And we want to remind you that there are technical errors that can be performed in a good surgery and turn the good surgery bad. Just as an example, for the gastric pouch in the MGB, if the two staple lines are here laterally close together, you can get ischemia, stricture, foreign body, and that often leads, in my experience, to ulcer, gastritis, and bile reflux. The other thing that we'll point out in the introduction is GE reflux is not just the MGB. It's one of the most common disorders we see today. 9 million visits in this study in the United States, 4.4 million most common gastrointestinal discharge diagnosis from hospitals in the United States. So MGB patients are not the only ones with reflux. In addition, outside of MGB, again, the incidence of esophageal adenocarcinoma has jumped from 4 per 100,000 up to 23 per 100,000, an increase of over 600%. There's some studies that almost 1 out of 4 or 1 out of 5 of every person in the United States has GE reflux. Again, not just MGB patients. And here's another study which showed how the rapidly GE reflux is increasing in the United States and less, but around the world as well, so that up to a quarter of all people on Earth have GE reflux, not just MGB patients. I want to think about GERD in the bariatric patient by three groups: the surgical procedure itself, technical errors performing the procedure, and post-op patient diet and lifestyle. So we'll ask some of the presenters to address these three topics. The surgical procedure itself, I think, could be described as that all, many, or most patients having that procedure get reflux. Surgical technical errors, that means that the results might vary based on the surgeon or the technique, i.e. good surgeons might have a good technique and low incidence of reflux. And then in a postoperative patient, we'd like to focus on diet and lifestyle. And results in the worldwide epidemic of GERD say that the GERD is amenable to treatment. So we'd like to hear a little bit about that. For those three topics, those three topic areas, those three subsections of GERD and the etiology, procedure, surgeon, or patient related, one possibility is the surgical procedure is just inherently flawed. And so the example of that is the Mason loop gastric bypass. That was abandoned fairly soon after the 1967 introduction because almost everybody got reflux because it violated a basic general surgical principle that we've known for more than 100 years. So the surgical procedure could be inherently flawed, and some people have said that's the MGB. I tend to disagree, but we'll talk a little bit about that. Is there an inherent flaw in some bariatric procedures, like the sleeve, that a very high percentage get reflux symptomatology? Is that the procedure itself? Is it inherently flawed? That's type number one. Type number two is that the surgeon actually is performing it differently, and the results in that situation may vary based upon surgeon and technique. For example, what we're thinking about is maybe a good surgeon with a good technique will report a low incidence of reflux. And so that's on a hypothesis that we'd like to see addressed by the presenters today. And then finally, post-op patients can have diet and lifestyle changes. And we think that we should be aware of that as physicians who manage people with GERD and be amenable to the worldwide data that shows that some things can be done to eliminate reflux. Even in patients who complain of it, there are things that can be done. So in the surgical technical errors, there are a variety of topics that could be discussed. One example, this is a surgical patient referred to me, and you can see here that we have a complete, almost 180-degree twist in the gastric pouch, and I think you can imagine that'd be difficult for that pouch to empty easily. And if bile were to reflux into that pouch, it would be delayed in its exit from the pouch. So that's an example of technical error. And of course, we talked about this technical error of making the lateral portion of the gastric pouch ischemic, and there are many others. The third topic is the post-op patient diet and lifestyle, and I won't belabor this as this is just the introduction. Post-op patient diet and lifestyle. What we know is for sure high fat intake and a low fiber diet will lead in high incidence of patients to GERD. And so this is just one study where it looked at the difference between a variety of diet and lifestyle factors. So midnight snacking increased the risk of reporting GERD by almost 600%, skipping breakfast, eating quickly, very hot foods, eating beyond fullness, meat, fish or eggs, high fat, less than 3 hours between dinner and bedtime, up to 7 times more, smoking, alcohol, and poor mental state. And in this study and others, a vegetarian diet decreased it by almost 60% to only 30% of the similar control patients. Physical exercise and also shown it's strongly related to the GERD, gastrointestinal reflux disease. So these are the things we look forward to talking about today. GERD, its etiology, whether it's the procedure itself, the surgeon, or the patient. And these topics I hope will be addressed by the group, and our interventions to prevent or treat using surgical interventions or lifestyle. And so with that, I'll welcome our first presenter, and thank you all very much for the invitation to participate today.